In the last video, we talked about the first-line pharmacotherapy for helping our patients with tobacco cessation, maintenance or controller medicines like varenicline, nicotine patches, and bupropion, as well as something for breakthrough cravings such as the nicotine gum or lozenge. We have major society guidelines recommending the use of these medications, varenicline mostly being the first-line one. I alluded to some of the evidence behind this in the last video, specifically the Eagles trial addressing psychiatric comorbidity when we were talking about smoking cessation, and also high-dose varenicline, which is a really exciting new topic for me that inspired me to create this video series in the first place. So I'd like to start with the Eagles trial, which asked the question, for patients with comorbid psychiatric illness, how does varenicline stack up in terms of smoking cessation and possible adverse events? Specifically, what they aimed to ask was, do varenicline or bupropion increase the risk of neuropsychiatric events compared to nicotine replacement therapy? So what they did in this double-blind, placebo-controlled, and active-controlled trial across 140 centers, 16 countries, 5 continents, over 8,000 patients, was compare the use of varenicline, bupropion, and the nicotine patch. Patients were separated into different blocks, whether or not they had different diagnoses or just no psychiatric underlying diagnosis in the first place. Patients included in the trial were aged 18 to 75, smoking half pack per day with a DSM diagnosis, except for the control group that had no diagnosis, excluded if they'd had alcohol use disorder in the last 12 months, or if there's any destabilization in their psychiatric illness in the last 6 months. So it is important to take that into account when we get to the final results. So patients set a quit date, and the follow-up was determined by both self-reported having quit as well as carbon monoxide measurements, which is pretty standard in these studies. So for the Eagles trial, our primary outcome was a composite of 16 neuropsychiatric adverse events. They also adjust efficacy following patients at 9 to 12 weeks as well as 24 weeks to assess quit rates. Unfortunately, there were a lot lost to follow-up, about 4,000 in each arm to start and 1,000 included in the final analysis. So the take-home message from the Eagle trial is that there was a non-significant difference in neuropsychiatric events when you compare varenicline, bupropion, and the nicotine patch. It's important to remember that obviously there's more events in the arm of patients that did have psychiatric conditions compared to patients that don't, but that's going to be expected no matter what they're taking. The important thing is that when you compare patients with psychiatric illness, no increased risk of adverse events with varenicline or bupropion. What we do see in both arms is that varenicline is going to be superior to both bupropion and the nicotine patch. There's tons of data from the table in the original article, which I obviously don't want to copy into a YouTube video, but I will summarize this data on your screen. And so in addition to reviewing this at your leisure, you could pause the video or whatever. I really do encourage you to download the whole article to check out all the numbers. If you think back to the last video, we had a patient with both major depressive disorder that was stable and coronary artery disease. She was coming in for tobacco cessation because she had a brother recently diagnosed with lung cancer. And so I want to talk about this extension of the Eagles trial, where over 52 weeks, they continued following these patients, and there was no increase in cardiovascular events. There's a theoretical mechanism for nicotine being a sympathomimetic and that there could be an increase in cardiovascular events, but obviously the risk of this is nothing compared to the risk of continued smoking. And so we even have American College of Cardiology recommendations to use any of these methods, varenicline being first line. So this brings us to the second half of the video about a recent article from JAMA from May of 2024 that really inspired me to do this video in the first place, because before this, I had never heard of using higher dose varenicline. What they did, and it was a small study, 491 adults randomized to either the 21 milligram patch with 2 milligram lozenges or standard dose varenicline, which is going to be 1 milligram twice a day or a total of 2 milligrams daily. So patients were assessed at 6 weeks. If they remained abstinent, then they continued the method that they had started and were reassessed at 12 weeks. But for those patients that were still smoking, despite having started the nicotine patch of varenicline, they were re-randomized to a new intervention. Basically, patients that hadn't quit when starting the 21 milligram patch were switched to either 42 milligram patches or varenicline. And for patients started on varenicline, they were switched to either the 21 milligram patch or increased to a total of 3 milligrams of total daily dose of varenicline. And so when we get to the results, what we see at 6 weeks, there was about 22% abstinence among patients that had started on the 21 milligram nicotine patches. 36% abstinence on the standard FDA-approved 2 milligram daily dose of varenicline. But for the rest of the patients, they were re-randomized to the interventions I just mentioned. So what I love about this trial, among those patients that were originally on NRT, 21 milligrams a day of the patches, they switched to varenicline, and we see a 14% abstinence rate. So for the patient that you might have started on a nicotine patch, this is giving us evidence to switch to varenicline. The same was true for those patients, if not switched to varenicline, their patch was doubled, 14% increased abstinence rate when going from 21 to 42 milligrams of the nicotine patch. So the kicker for me, when you add an extra milligram every night, instead of the 2 milligram approved dose of varenicline, 3 milligrams total daily dose, we have 20% that were able to quit smoking that weren't with the original 2 milligram total daily dose of varenicline. So this is really practice changing for me. I might add that higher dose nicotine patch or a higher dose of varenicline. They're off-label, so it's really important to explain that to your patients. You have an increased risk of side effect. We don't have FDA approval for this. And then, of course, with varenicline, few studies limited to one center and a small group of patients, but nonetheless, giving us evidence that this might work. And we have so few options, just varenicline, bupropion, and nicotine replacement therapy, that it's a great place to start. Obviously, you'll notice that I've avoided e-cigarettes and other alternative options in these two short YouTube videos. I wanted to stick with the FDA-approved option, as well as the high-dose nicotine patches and varenicline, but it's something worth looking into. There's preliminary data that shows that it might work, but again, not something that I'm doing. Look into it and see if it's something that you do want to incorporate into your practice. And if you do, comment below about that. I'm curious to see how it's going. And if you're using varenicline successfully or higher dose nicotine patches, I want to hear about that too. So put that in the comments. So to summarize, don't forget about varenicline, bupropion, and nicotine patches, and consider higher dose patches or higher dose varenicline to help your patients stop smoking.